Hey, I'm Brad Clementson with the Mint Condition Podcast. Today we've got Dr. Brandon Carter joining us from PI Sciences. Thanks for joining us.
You bet. Thanks for having me on the show.
This is really exciting to have you here.
Yeah.
You've got your own podcast, right?
We do.
How do people find that?
Oh, they go to Spotify, Apple, Injuries and Evidence Show.
Injuries and Evidence Show.
Yep.
Perfect. And on that
Yeah.
podcast, what's your main goal?
Our goal is to help everybody understand that when it comes down to traumatic injury, how do we diagnose, what is the prognosis, and how do we treat those and get a patient to maximum medical improvement faster? How can we accomplish that? Really, that's our goal.
I love that.
So we interview so many different physicians, to attorneys, to even other software companies, because there's a ton of software, especially AI right now.
Yeah.
Right? And so we're like reaching out to all the AI companies, trying to understand how do physicians actually work with AI, especially if you're doing personal injury side.
Yep.
You know, what is it that will help them achieve maximum medical improvement faster? So our show will definitely cover A to Z on that.
That's awesome. Well, anybody listening should go check that out. Learn more
great.
about auto accidents, the science behind it, all of that.
Absolutely.
Well,
good.
let's go through your bio really quick.
Let's
and
do
then we've got a lot of stuff to cover today.
Okay.
So Dr. Carter earned his undergraduate degree in 2003. That dates you a little bit, huh?
It does. I guess I'm getting to be an old man. You can see the gray in the beard,
Yeah,
though.
it looks good. Pull it off.
Thank you. You think so?
Oh,
good.
Heck yeah. At the University of California,
Yeah.
right?
Yep.
He studied biological psychology for 5 years.
Yep. Biopsych.
And then you were involved in studies performed at the Mind Institute at the UC Davis.
Yeah. Yep. That's what changed my direction.
Okay. So you weren't planning on chiropractic yet?
I wasn't planning on chiro. No, I was going into psychiatry. So everybody pre-med was in biological psychology.
Yeah.
And then I went to the Mind Institute, and they were seriously like, when you go to the Mind Institute, they're pushing pills like under the door to the patients there. And then they sit around like we're doing right now. Just sit there and chat and write their chart note. And I said, this seems kind of boring to me. And they said, oh, this is all you do, man. In psychiatry, welcome to, do you want to just keep shelling out psychotropic drugs? This is what you do.
Wow.
And then I said, I mean, it scared me because I was like a senior. That was like junior, senior year. And I was like, okay, what do I do? And my mom had married a chiropractor. And so he's like, have you ever thought of chiro school? And I was like, I had been thinking about it off and on at times, but I definitely was heading into psychiatry.
Right.
Until I went to the Mind Institute and I realized this sounds so boring. So I was hugely into golf at the same time. So it was like, can chiropractors work with golfers? And my stepdad was like, that they love it. And I'm like, that sounds cool.
Yeah. Combine your hobby and your work, right?
Yep. Change of plans.
Yeah. That's really good though. When you can learn that, sooner the better. A lot of people don't find out until it's too late. They feel stuck.
Yeah, that's true.
Or whatever. But probably a really good background, right? Helped you as you got into chiropractic school. Looked like you went to Life Chiropractic College West in California.
Yep.
That's a school I hadn't heard of.
So Life West is kind of the home of Dan Murphy.
Okay.
Dan Murphy is internationally known in personal injury. I studied under him and then studied under Don Harrison. So if you've ever heard of chiropractic biophysics, which is the most researched technique, I really would only, if there's any chiropractors out here that are listening right now, I probably don't go to anybody but a biophysics chiropractor because they've put in some extra time,
right?
Probably extra years into study. It's the most researched technique.
Yeah.
In the practice of it, evidence-based best practices have been published through chiropractic biophysics. So amazing program. And then so I studied under Don Harrison, who has passed away. And then Deed Harrison, his son, now is the head president of chiropractic biophysics. So he he runs it.
You were saying that it was like a 3.5 year program, right?
Yeah, it is.
So you're not just get in, get out, get licensed, and go pop some people.
Yep,
right?
You're right. Yep. Yeah, so I got out of school and then ended up going to about 2 more years of postgraduate. And that was in traumatology.
Oh, okay.
So once I did that, then that was more like, hey, MRI interpretation, radiology interpretation. And then you get into the traumatic injury, spinal biomechanics, ligament laxity, ligament damage. That's why I was saying kind of earlier, let's talk cervical instability, because it's really the most underdiagnosed, I would say. Diagnostic code, I want to say. So I'd rather have people analyzing for cervical instability post-trauma rather than and using M53.2x2 codes, 2x3, 2x1 codes for instability, and a lot of them don't. And then M2428. If you don't use those 4 codes, you're missing out on everything. Like most people put sprain, right? And you had mentioned that earlier. It's like, yeah, you can put sprain, that's good. But what grade is it? The code doesn't allow you to put that in there. The ICD-10 codes won't allow that, right? So if I just put sprain, then an insurance company is just thinking, well, it's probably just a 4 to 6 week treatment plan.
Right. Versus
M532X2 is more of a 3 to 4 year treatment plan. So it changes things for you.
So not only...
And that's just a one code thing, right?
It not only helps the patient and kind of establishes what's wrong, but now you've justified long-term care.
Yes. Amen. Exactly. That's exactly right.
That's cool.
And so you got to make sure that as a practitioner, then as I, studying under some of these guys at Life West, it was super helpful.
Yeah. So
because then I came out of school going, I already had pretty much a nice background, and then went to more postgraduate studies and then took off from there.
Yeah, you've got.
But I wasn't going into PI. I mean, I was going into, my world was into golf. I was totally wanted to work with golfers.
Yeah.
And in fact, I wanted to move down to Southern California, but my wife did not want to at all because her family had moved here, and I wanted to go down to Carlsbad, and I wanted to open a practice down there with golfers, like 20 golf courses around, right?
Yeah.
Or like right around your practice. That'd be awesome. But then I got hired on into if you want to know a little bit of my background in PI was more like I got hired on at a practice in San Francisco, and then he would hand me the patient's chart, and he would say, hey, can you write a nice narrative report for this case or whatever? And then I was looking at his narrative reports, and they're like 2 pages long. And they wouldn't describe any of it described like mechanism of injury, maybe a few diagnostic codes in there. And then I would look at it, and I was looking at the x-rays or MRIs, and he wasn't applying any of the diagnostic codes from MRIs or x-rays or any of that stuff. And so I said, well, why don't we, and my background was research at UC Davis in biopsych. And then at Life West, I was, studying research there in chiropractic biophysics. So then I was like, well, why don't we start applying some of these research articles to these narrative reports and to support the patient, number one. I mean, it's our patient. Remember, we become a non-retained expert the minute you do an exam. The minute you lay your hands on that patient, you bill out, you're a non-retained expert. Right. You're probably going to be deposed on it. So we always begin with the end in mind. And I learned that really quick, and it was, so once I started writing narrative reports for this guy in his practice, they would end up being like 10 to 15 pages long. And then an attorney comes over one day, and he's like, what the hell? Who wrote this? And then the guy who owned the practice, he goes, I did. It was so funny. And I'm sitting in the back room, my room at the time, he gave me this room that was it was probably like 5 feet by 5 feet.
Yeah. With
a smaller door. It was a really weird closet. And then the desk he gave me was like super tiny. And then he had put this stack of chart notes that I had to write narrative reports on. And I was like, sure, let's do it. I'd love to dig through these chart notes. Yeah. And so I just started I worked with him for a couple of years, but then I just started figuring out these narrative reports, and it was attracting so many of these attorneys around his practice. Yeah. These firms are coming in, and he was stoked. Dude. And he was taking all the credit though the whole time. In fact, he would sign it. He would sign the narrative report at the bottom, and I'm like, that's all right. It's okay. He's paying me.
He's paying you, but still.
And I was learning.
But that's the cool part is you took that opportunity to learn to better yourself. Yeah. And now you use that to educate others. right?
Yes. So then I took those narrative reports and then we ended up packing up bags and split and moved to Utah. And then once we got to Utah, then I was getting a lot of personal injury cases in my practice. And then the attorneys were like, hey, this is cool. I'll pay you whatever you need for this narrative report because this is super helpful for me to really explain from A to Z what happened with the patient and the entire spinal biomechanics of their injury. And here's some research articles that support it and support my opinion. They loved it.
Yeah.
And so then they were like, so how do we get more of these? And I was like, I don't know. So what I was doing is I was taking Microsoft Word, making templates on Word on an old Dell laptop computer, and like just writing narrative reports for other practitioners and stuff. And then
so you just summarize all of their care or the whole case's care. So you take the PT, chiro.
Yeah, that's a great question. So in the beginning it was just the chiro care. And then as cases moved on, then more attorneys were finding out about, who I was. Then they were like, hey, can you do a total peer review? And then I was like, sure, let's look at all that. And then I started realizing these practitioners, their diagnosis, prognosis, and treatment of the patient was way off. It was like they were definitely not reaching maximum medical improvement. And I learned a ton with that, with just me doing my own. And it all started with a narrative report.
Right.
I remember reading the one narrative report in California, and I went, this could be written a lot better. You're missing a ton of info.
Yeah. So is that something every provider should do at the end of their care on every case?
It depends the state. So I still say in California, then I would be writing a narrative report. In our state, it's definitely a little more wild, wild west here, right? Utah's a little easier.
Okay.
But if you can sit down on your final, say, SOAP note or whatever, or chart note, and you put together a nice narrative report that explains your entire treatment plan, oh man, then you're bound to get paid on it.
That's cool.
Versus like cutting your bill,
right? Yeah, instead of just
because you're going to help significantly.
Yeah, that's cool.
And I could see that from a claims adjuster view too, right? It's like, wow, this doctor actually took a lot of time with this patient
and actually thought about what they were doing instead of just stuck them in the system.
Yep, that's right. Yeah, instead of a mill type of therapy center or something.
So how do people learn all of what you've learned? I know that you've taught occasional courses.
Yep.
I went to one of those courses.
Yeah, that's right.
Is that the only way that you teach, or are there other ways?
Yeah, so you can jump on a webinar program with us. It is very specific per practice. So you have to give us a call, and then we'll sign up with you and subscribe. We have free stuff to, subscriptions.
Right.
Depending on the size of how many people we got to teach. Do we want to actually do hands-on training, et cetera? So, but yeah, they can totally just reach out to PI Sciences.
That's really cool.
And then we will make it happen for however much you want to do. Do you want to just take our 5 free courses and understand a little bit better, understand insurance, understand the way they think? Because I'm always on the insurance side where if you come to my class and you'll hear me say, a claims adjuster is always right. And that upsets a lot of people.
Understandably.
But why is a claims adjuster always right? Because they're just going to go off of the documentation they receive, right? So they're just looking at that. So if your documentation sucks and you don't know what you're doing, then claims adjusters are going to be right. So they're always right until you prove them wrong.
So
and then you got to come out with your better documentation.
Yeah.
Totally.
That's cool. So at bare minimum, everybody should do your free classes, right?
Yes. Yep.
And those free classes cover, like you said, everything from the insurance perspective, things you need to document. Does it go into any of the stuff that's like preparation for being deposed? Or is that more of your advanced?
That's more advanced, yep.
Okay, cool.
That is a little more advanced. We do have we have injuries and evidence experience. That's what we have twice a year. I think that's what you came to.
Yeah, that's what I went to.
Yeah, and that's free, or I think we charge like, I don't know, $40 or something. I was like, if you can't afford that and you're in PI, then
Well, and it was,
You might want to start
you're doing
thinking of
something
a different profession. I don't know.
wrong. Yeah, you're doing it wrong. But
I mean,
yeah,
I'll pay for you just to come so that we can have
Yeah.
better practitioners out there.
Well, that's why you're doing your podcast. That's why you teach these courses.
Yep.
I think it's really cool. You took this opportunity to learn, to say this wasn't good enough, and then saw that most providers out there have this hole. I also think most chiropractors and physical therapists, I can't speak for pain docs and DOs or MDs or whatever, but PTs and chiros, I think most of us are scared of auto accident.
Yeah, I
And
think
if
so
you
too.
can just have this foundational knowledge, you're like, oh, it's organized. It's not just nobody knows, good luck. There's an answer.
Yeah, that's true. I think a lot of people are scared. I know I was. And again, it comes down to deposition and trial, though. Begin with the end in mind.
Yeah.
You got to begin with that end in mind. And then don't let that scare you, though. Just make sure that your documentation is solid. You support every diagnostic code that you're using on there. And as long as you support it with evidence, then you're going to be fine. And I know in my first deposition, it was I had no idea what to expect. Nobody ever told me what to do, or I called, this is what the attorney told me. Hold your breath for 1 second. Here we go. Ready, set. Just be yourself, Brandon.
That's it.
That was it. Be yourself, Brandon. And I said, so what do I have to, what are we doing? Really, it came down to that. Like, what are we doing? He's like, well, you're just going to get asked a lot of questions from another attorney about the treatment of your patient. And I said, so how do I prepare? Just come in and be yourself. You'll have your notes.
Yep.
And I was like, but I learned so much in that first deposition so many years ago. And I remember going home that night and I could not sleep.
After?
Yeah, after.
Okay.
I mean, my brain, so you guys know me, I'm a total ADHD guy. Like when I get honed in on one thing, I'll get honed in on it, but then all of a sudden it's just squirrel. Like, cause there's so many things going on in my life. Right. And then I'm like, but that I'll never forget that after that first deposition that night, like I wasn't talking to anybody. I just disappeared, locked myself in my bedroom, laid down. And I was like, I think I even got a little emotional. I was like, I just blew it for my own patient.
Yeah.
I just blew it because I love my patients. And I'm like, dang. And so what I did is I ordered, so you can order from the stenographer, you can order your notes.
Oh, cool.
And so I did order the notes, and you can make any changes you want in your notes. If you need to change some stuff or whatever, you can read through them. I highly recommend that. Like if you're deposed on anything, tell the stenographer you want a copy of the notes. They'll email them to you or they'll mail them to your office one way or the other, and then get a copy of them and then spend some time and read through them, and you're going to just laugh at some of your answers. You can be like,
why'd I say that?
what the hell? Why was that?
So if you modify this, does that hurt your testimony?
Not at all.
At all?
In fact, you have to, like if you said something in there that is not really not accurate,
right?
Especially scientifically based or something like that, then you're going to sit down and when you want to change it. You want to cross out that sentence that you said and write in what you actually meant. And that does not hurt the case. Okay. In fact, it's better because if it goes into court, which it's very rare, but if it goes into arbitration and you have to go and testify there, or it goes into a courtroom with a jury trial or a bench trial. And I've done all of those. But like I have had to cross out many things. I was like, man, why'd I say that? What the heck? That was not even applicable. That was stupid of me. So I just put a line through it and just initial it. And that's all they want you to do.
And I'm guessing the copies of this get sent to the other lawyer. And
it will. Yeah, both sides will get a copy. But what's going to happen is when you're in court, then that defense attorney, if you say something and they're a smart defense attorney, and there are really stupid defense attorneys out there that are, especially out here in Utah, that they, like I had one defense attorney trying to tell me that we're not allowed to read digital x-rays. In fact, you're not even allowed to take digital x-rays, are you, Dr. Carter, in Utah? I'm like, digital x-rays? Wait a minute. Let's see. The hospitals use digital x-ray. So there's some really interesting defense attorneys out there that you'll find that, and then they end up kind of waffling away from being a defense attorney and going to, plaintiff work or something else.
Yeah.
They bail out. They're just trying to make some money. So,
Yeah.
and I don't blame them. So they'll try to find all your errors. And so if you do say something wrong, then, and you go into court, then they're going to ask you that same question again and see how you answer it.
And see if you
and if you answer it different, then you're going to get impeached because now you've lied, right? You've told two separate opinions, and then they're going to impeach you because they're going to point it out to the judge, and the judge is going to say, "Yeah, you're toast.
Yeah.
Thanks, you're not an expert." So you really got to make sure you read your notes.
Yeah. Are you?
And so what I did that first night after my first deposition, again, that destroyed me. I mean, my cortisol level was up for probably 10 days. My adrenals were on fire, guarantee it. And so I remember laying down thinking about it, and I was like, dang, why did I say that? Why did I say that? Anyways, and next few days I got a copy of the deposition, and then I reviewed it, and then I started writing down everything that was coming out of that whole thing. I started writing down like, ooh, I should have answered it this way, and I should have answered it this way. And so that's what started our deposition training courses.
Cool. Yeah. And I think that's so important for anybody to learn, because if you're a medical provider, you're going to run into situations, even if you're not on PI, where PI, it makes it more likely, right? But if you're working with people post-surgical and they get an infection and it dehisces or whatever, you could get deposed. You could. You've got to know all these things.
In med-mal, that is a huge part of it too.
Yeah.
So understanding. Now there is a new company that is they've only been around this year, and they have an actual software system for deposition, and so there's a lot of law firms that are using it. And from what I understand, I just met them yesterday, and but what they're doing is taking your deposition and recording it during the deposition. Not just a stenographer, because again, it was like back in the day, it was just a lady, or usually it was a lady sitting there typing, and so now the software will actually analyze everything you say, and then kind of like ping if you're not telling the truth, if you're not saying the right thing or whatever, it'll recognize it.
Contrary to like research and stuff like that.
Yeah. Yep.
That's cool.
Yeah, it's pretty slick.
So it helps you because then you can check it, change it before you get called into court or something else. That's cool.
Yeah, it is cool.
So what if you miss something? You get a hypothetical, but you miss something, you get into court, and you're like, well, let me check my notes because they asked this before.
Yeah.
I answered this, and I did some research after I got deposed, and I found I'm wrong. And I said that, but just clarify. Point it out.
Yep, just point it out.
As opposed to getting impeached.
Yep.
Yeah, because it's tough. I think at the end of the day...
I just say stress not.
Yeah.
Be
honest.
Call me, first of all. If you have a deposition coming up, give me a call. Let's talk about it.
Yeah.
Let's figure out what you're being deposed on. And then if it's PI, I mean, really, I know more and more about less and less, right? It's like, I know 3.5 millimeters of translation and is instability, right? Yep. And that's always my hyper focus as a practitioner, and that's usually why I'm in deposition, is just to explain that one little thing. It's like upper cervical instability. And you want me to explain that? I'll explain it to you. And we get into it for 20 minutes of explaining it, and then explaining it to a jury, making sure they understand it, and really that's all you're hired on for.
Yeah, but that's with you where you've been able to hyper focus.
Yes.
For a lot of providers out there who are generalists and they're seeing a variety of things, right? Makes it a little bit trickier.
So and that's the difference between non-retained and a retained expert, right? So I've been a retained expert in many cases because they want me to just focus on this one thing, right? Where a non-retained expert, your notes are that's your case, and you better be able to explain every little step on it. But I say fear not, in the sense of we have so much software now, in our day and age. Yeah. It's like you just have to you got to be thorough though. So this is what I see. The biggest weakness, especially for PTs, chiros, many MDs that I know, and when I read their notes, I sit there and just go, okay, They took the vitals. They explained mechanism of injury, kind of, just said like rear end collision, right? And then if we go through that entire chart and then you go down diagnosis, then it says cervicalgia, lumbago, although the MD has an MRI in their hand, or they need to review it, as they're treating the patient or whatever, or whatever's going on. They have the MRI. They do know there's a disc herniation. That's why they're in there. And then, so they wouldn't even put diagnostic codes of, even just cervical disc disorder, which is a very easy code to look up on your software.
And the easy code to justify. You're not.
That's right. So you're like, I've got the MRI, and I type that in, I've reviewed the MRI, or I'm going to send the patient out for an MRI to rule in and out space-occupying lesion, cervical disc disorder, infection, inflammation. You can put whatever words on there. You just you have to say you got to rule it in and rule it out.
Right.
But especially after trauma. Why would you not want to have that as a practitioner?
Right. That's what your job is.
It is.
That's what it comes down to.
Instead we turn ourselves into technicians to where the patient comes in, you do an exam, and then you're like, okay, let's just throw you on E-stim and I'll teach you a few exercises and have a good day.
Yeah. And
that sounds boring to me.
There's no clinical reasoning behind it. It's just
you're right.
Hope and a prayer.
Yeah, no differentials, no differential diagnosis.
Yeah.
And that's one of the courses. I mean, I have so many different programs that practitioners can take, from differential diagnosis to, and again, diagnosis is the number one driver for insurance. It's what drives everything.
Yeah.
So if your diagnosis is poor, then you're more likely, and say it's poor diagnosis of cervicalgia, and then you treat them for 30, 40 visits or whatever, they're coming in your office.
Right.
And then you're putting down that the neck pain's kind of going away, and that's all you have is the diagnosis of cervicalgia. That's just a symptom code.
Right.
So your first codes need to be an actual objective finding code of like an injury of some kind. I don't care, what we're talking about. Tear, sprain, right?
Yeah.
And then you can put symptoms, but why even waste your space on a 12-box CMS 1500 form? Right. Why waste it with cervicalgia, right? It's like, why put that code in there when you have a cervical sprain or a cervical disc disorder? They have cervicalgia, I guarantee it.
Yeah, that's kind of guaranteed.
So don't throw that in your note. Don't put that in as a code.
Yeah.
And claims adjusters just look at that stuff and laugh.
Yeah. They specialize in that, right?
They are so trained.
They get those codes down.
And they don't, and I think that's what also makes some docs nervous. They're like, I just don't even want to deal with an insurance company.
Yep.
But if you're going to do personal injury, if you are going to accept cases, then you better do it the right way.
Yeah. Yeah. One of the other things that I learned from your class was about MMI.
Oh, yeah.
So I've heard some different opinions since the class on use it or don't use it. A lot of people say don't ever put MMI in your charting. Yep. I've heard a couple of people say MMI as far as physical therapy goes, or as far as chiropractic care goes.
Yeah.
Is that good, bad? What have you taught?
That's okay. I like the, I don't see a problem with here's the thing. Really, what is the prognosis, right? So you got to think of, is it going to be ongoing treatment? Is it poor prognosis, ongoing treatment, and ongoing complaints, ongoing treatment? So if it is still ongoing complaints, then don't put down MMI.
Right.
Or I've seen it where just a chiropractor puts down cervical spine has reached maximum medical improvement. And I'm like, but that final exam, they still had ongoing complaints. They're like, we still recommend further treatment, but they've reached maximum medical improvement. And I'm like, okay, so you just kind of like screwed everything up.
Yeah.
So I think in a general way, like most guys in the legal world would say, hey, doc, don't put MMI on anything, please. You're ruining all of my cases. Although it's great to know, like a claims adjuster should know, hey, the right wrist has reached maximum medical improvement, static maximum medical improvement. So we have static versus stable.
Okay.
So make sure you're
difference of
putting that. So stable means have reached, they're stable, they've reached MMI, and the right wrist needs no further medical treatment, period.
And that doesn't mean they're at 100%. It's just the best they possibly ever could get.
Yeah, and it's stable. They're not going to get any other treatment. Now, if you put static MMI, that means there's an ongoing complaint, ongoing problem here. There's a functional loss possibly with the wrist.
Right.
And thus they can get further care.
So it leaves the door open for other treatment, but also for like an impairment rating or something.
Yes.
Okay.
So you have to have static MMI to give that impairment rating.
And
you have to have that duties under duress, loss of enjoyment, ADL side of things filled out, and at least somewhere it's got to be in your SOAPs, somewhere in it.
All that stuff, ADL stuff, could just be in any treatment note, right? It doesn't have to be its own thing.
And I get that from an insurance side. That's what they want to know. They want to know, hey, how's it affecting their work? How's it affecting their sex life? How's it affecting their family life? How's it affecting, et cetera, et cetera? Can they mow the lawn now? No, we can't. They have a tear in their right ankle, and they may need surgery. They're doing PT, and for X amount of visits. But again, even from a physical therapy perspective, I think most physical therapists would say, even after 12 visits, they still need ongoing PT treatment, just to maintain where we've gotten them to. I mean, we know the way a muscle works, right? And it's going to atrophy, like once you're done with PT.
Yep.
Unless their home treatment plan is like on it, and you're following up with them, and you're going to their house or whatever, and you're following up once a week.
Yeah.
Otherwise, atrophy is going to be a problem.
Then it's gonna lead to that.
It will lead to it. So write that out. Put that in your note. I mean, even write those thoughts out. Like I put it all the time. I'll say, their right ankle is unstable. I'm concerned about muscle atrophy because I'm going to release them from care for right now, but I still want to see them at least 2 to 3 times a month to follow up on this while they go get other further medical treatment or something like that. So I still wouldn't put static MMI on there.
That was my next question. So you wouldn't put static MMI there
because I'm going to referring them out.
Right. That's when it's like, hey, I'm done with all treatment, and now I'm doing it. Here's a situation. So I've got a patient who's going to probably need surgery, and so I'd like to write a future cost of care type letter, and maybe even an impairment rating right now. Right? But you wouldn't put static MMI because there's still a lot of future treatment planned.
Yeah.
Right?
So I would say then as of right now, I would not give an impairment rating.
Okay.
Because you look at the definition, go to page 2, AMA Guides, 5th edition, right? And you read what is maximum medical improvement, and it's the patient's reached a point that they may or may not need, or their symptoms are not going to change with or without treatment over the next 12 months. So if you're thinking, and their symptoms, they could crumble over the next 4 weeks without seeing me while they're waiting for surgery or something like that, then I can't give an impairment rating yet. Send them to that. Well, if you think
stable.
But I would say if you are referring to a surgeon, I would wait till the surgery's done and then call them and be like, did you get the surgery done? Did you do the PT afterward, post-surgical PT? Okay, get back over here. Let's finish your PT side. Let's get you to that point where I know it's stable now.
Right.
That's stable MMI in a sense. Although I never use the word stable because I don't know. I think I have a hard time like trying to play God in a sense, like, cause I don't know what's going to happen in the next 4 to 6 weeks where, as a practitioner, I'm like, I have treated thousands, I've treated into millions of adjustments, right? And thousands of patients in personal injury. And it's like, man, I swear, I don't know how many of them, what percentage it is that come back to your practice. I'd say 3 to 4 months later going, man, I tell you, that neck pain has totally flared up. I mean, it's come back.
Right.
So stable means no further treatment. Static means
whiplash,
they may need further treatment.
Right. So I think that's always going to apply in a car crash, right?
Yeah.
With whiplash, anything involved in the neck, I've seen it where even 2 years later flares right up. Yeah, and it's like, if they weren't in that car crash, would that have happened? Yeah. Right? Even just living their day-to-day life.
For sure. That's a great way to look at it too. And if you think about it too, like there are multiple studies that show where they do, the patient has settled the case. I've had so many defense attorneys ask me, well, don't you think that this future care plan or whatever you put together, you're just trying to give the patient more money, right? And that's always what they're going to paint the picture as, of course. However, with my examination, in my exams, I do a lot of malingering tests. Is there any kind of exaggeration of these injuries at all? And I do ponder on that side a lot, and there are some great malingering tests that are, 95% accurate. It's like there are some really good ones, and make sure you do them, and then that way you can have, more of that medical opinion, when you're finished with that treatment plan. But I still would put static maximum medical improvement and have them return in my future care plan. So at least one time a month, for the next, 12, 24 months. Yeah. Let's see how they go through another year of winter. Yeah. How is it in Utah?
Yeah, it changes, right?
What happens now? What happens with ligament damage? And let's get into the research of osteoarthritis.
Yeah. Totally opens up so many potential issues down the road. And how is that patient going to do 6 months from now with that ligament and arthritis? Amen.
And what if they already have osteoarthritis, spondylosis or whatever, or stenosis of the spinal cord? In Utah, it is an eggshell doctrine state. So eggshell meaning like, I don't care if they're 99 years old or 101 here, like we have seen in a few men here in Utah lately.
Right.
I've seen, so you hit 100 years old, 101, and you're in a car crash, you got to accept the spine the way it is. Guarantee it's going to be bone on bone.
Right. They're going to be a very different situation, but that doesn't mean they weren't hurt.
Doesn't mean they weren't hurt.
Yeah.
But, and that's where I really wish, like, if I could have just the wish of my heart, it would be that a claims adjuster would see that perspective from eggshell views. And I think some of them do. There's some really good ones that I've talked to and had great conversations with, and they're like, hey, I get it. That makes sense. The problem is my senior authority over me.
Right.
That's the problem, and then it's like, well, someone's going to have to give in.
You're just doing, I think that's the biggest thing I've learned is just, like you said early on, just be you. So
just be
do your job, show up, do your job. And people will disagree, and that's okay. And at the end of the day, that's when, things really progress and you've got a judge involved or whatever, and somebody else decides. Just stay being you, because you don't have to accommodate for other opinions.
Yep.
Just be you.
Good. I've sat there in a bench trial one time. This lady, the judge, she was like, so when you're in a bench trial, there's no jury involved, and it's just the judge making that decision, final judgment. And she can ask you questions. So she can, you can't in a jury trial. I mean, they can, well, I don't, jury, I'm not the attorney here,
right?
But from what I understand as an expert witness, the judge in a bench trial can ask me any question they want,
right?
And so they'll ask for clarification or something on a few things, and so I've sat there and I'm like, and my problem is I'll get passionate about like the research, and I'll be like, man, check this out, I'm sharing it with a defense attorney. Well, and I always bring in a binder, so I have a binder for my trials that I've designed. If you guys want a copy of it, let me know. I'm more than happy to just hand them out.
Awesome.
But it's like you'll get everything from cervical research, thoracic research, lumbar research, everything from lumbar nomenclature to definitions of spondylosis versus anhidrosis of the lumbar discs, and our disc protrusion versus disc bulging on the MRI scan or whatever. And that's what the judge will always ask you questions on. Like, so what does this disc bulge mean? Does that mean herniation or what? So I've sat there with the judges before, and it's like, man, let me just tell you exactly what's going on with this guy. And defense attorneys don't like that at all, because then you're like, no, I can see why this guy's rocked, because you look at this MRI, let me show you the picture. And then you'll show the judge the picture, and they're like, dang, I had no idea that a disc would actually do that. I didn't know that like one of my favorite studies is always the showing a disc in a younger age has, the decreased nociceptors around the outer annulus, right?
Right.
Decreased nociceptors, but as we age, they penetrate deeper and get into the nucleus of the disc. And we increase by like 10x, on nociceptors, pain receptors.
Yep.
And it's like, and I've shared that with so many judges. That study, I'll hand it over. You can hand it over to a judge in a bench trial and go, here, check this out. And then they'll be like, so what you're saying is he's more likely to have ongoing pain because of his age.
Right.
It's like, there you go. Absolutely. Look at the research on it. I mean, there's tons of it. There's nothing. So
are they using that to blame it on the injury on his age? Or is it he's going to experience more pain because of his age, but that's not his fault? He's still got
They're going to experience more pain.
Okay.
Yeah, and that's what. And so thus the ongoing complaint is more likely due to the age, and rather than blaming it on the disc degeneration for the injury, it still was the car crash, right?
Right. That makes sense, because I've seen a lot of situations where they're trying to blame it on degenerative disc disease.
Amen. They do it every time.
Stuff.
I would too if I was an insurance company.
Yeah.
I'd be like,
well, of course he hurts. Look at this.
Yeah. He's got
it's like,
arthritis.
Yeah. That's cool.
But what I do is I'll plug into my note or whatever. Hey, you know what you got to understand is that it's eggshell in Utah. That's the way it is. And I don't know how every state is, but Utah is eggshell.
Yeah.
To where you have to accept the patient as they were at the moment of the crash.
Right.
You can't blame it on past prior medical history stuff. So
yeah, it's like, well, if I crashed into somebody who was 12 instead of somebody who's 80, it wouldn't have cost as much. It's like, yeah, but you hit someone who's 80.
You hit someone who's 80.
So next time, aim better.
Yeah. That's good. That's funny.
So it sounds like impairment ratings have timelines on that, right? Like certain situations to prepare for.
Yeah.
Do you ever run into FCEs for these auto accidents, and what would make you choose between those two things?
So FCE definitely have referred out for a ton of those. Like, and what usually, so when it comes down to like AMA guides, right?
Yeah.
Then we're talking functional loss. So of the person. So what we're looking at is whole person impairment. So I'd provide the whole person impairment and functional loss first. And then the next question is, can they work? Or are they disabled? Or do they have to change their work, plans? Or
so
what's the...
Are you saying FCEs on top of an impairment rating?
Yeah, for sure.
Oh, okay. I always thought of it more of like one or the other.
No, I would do both.
Okay.
Yep.
That's cool.
As long as there's enough in that, again, that comes down to an insurance situation, right? It's like, what is the policy? Is there enough money to pay all the doctors trying to be that are going to be involved in this situation?
Well, and
we do have to consider that. We got to keep that in mind, and that's fair.
And the lawyers help with that, right? They're saying, hey,
look,
we don't need the FCE because we're already hitting limits. Just give us the impairment rating so we know where we're at. But if limits are 300,000 and we're at 25, it's like, then what is the FCE? Okay, they can't go back to work. They have to change jobs. That now qualifies us for a little bit more of that money for the patient. Right?
For sure. Yep.
Okay.
Yeah, pain and suffering, and then what about disability, right?
Yeah,
SSDI.
Exactly.
So then you're going to get into that side of it, right? So I always say definitely, if you look at a chart, and I'm not sure what page it's on in AMA Guides 5th edition, but you'll see the chart where it says, they have the injury, and then you have functional loss, and what are they? What is functional loss with that patient? Make sure you're documenting all that. And then what is the impairment rating? Then the next step is, can they work? Yes or no? And then it's like disability, yes or no. And then, but that's where I get into the functional capacity side. And then it's like, how are they? how many times have we seen like construction workers here in Utah that were in a car crash and, man, they are wrecked. And you see these spines that are just destroyed. And you're like, okay, so now you're a construction worker. They're bending, lifting, twisting, and all day long. How are you going to do that? So there's nothing wrong with communicating with the legal side, like, hey, how much is there enough available to get a functional capacity exam? Because I would always say that.
That's cool. Yeah.
I would encourage it.
Yeah, as much as possible, right? When
much
appropriate.
If you can. Yep.
Yeah,
do
that's
it.
Cool.
But give the impairment and then apply it to the functional capacity evaluation.
Yeah. Well, I've got a final question for you.
Yeah.
But first I want to summarize. I think the biggest takeaway from what you've said today is start with the end in mind, right?
Yeah. That's huge.
You got to plan on that. And you don't know which case is going to need arbitration or whatever.
Yep.
So start with the end in mind.
Yes.
So my last question, and I ask everybody this, I normally warn them beforehand. I don't warn you.
No,
so
you didn't warn me.
Gosh. I always ask, what does mint condition mean for you?
Ooh, mint condition.
Yeah.
Wow. Well, I always think of a coin, I guess, when I'm thinking of that. Like, and it's right out of the mint, right? It's like shiny silver, bright, brand new.
Yep.
Coin. So that's what it'd mean to me. Like, I'm in mint condition. I am like brand new.
Brand new. Best you could be.
Best I could be.
I love that. That's a good way
to say it. But I would definitely be thinking of a coin because it's right out of the mint.
Yeah, I like that.
So that's how it would to me.
What's the best way people can reach out, find you, other than just Googling PI Sciences?
Yeah, so anybody's welcome to send me a text message so anybody that knows me with PI Sciences knows I suck at emails. Okay. I'll never check them. So good. I don't know. It's the worst.
Send emails.
Don't send me an email. But you're welcome to send me a text message anytime. 435-709-1447.
Perfect.
And send me a text message. Just give me your name, and I'll be happy to answer any questions, especially if they're facing any depositions, expert witness situations. And I think we need more practitioners, though, that are they're at least trained in deposition and trial, and maybe they don't want to be an expert witness or whatever. But I think that every practitioner should.
Yeah.
Personally.
It opened up my eyes to it. So I'm really glad that you're doing what you're doing. I think it'll help our community.
Well, thank you. Appreciate it. Well, we're excited. And it's like, let's go. Let's make it happen.
Well, we'll get the
Let's change the world.
Heck yeah. Well, thank you. Thanks
You're
for
welcome.
coming on.
You bet. It's good to see you, man.
Yep, you too.
Have an awesome day.
You too.